Good afternoon. Thank you. Good afternoon. So, welcome. This is the UCR School of Medicine's Black History Month lecture featuring Dr. Mario Sims. As I drop my papers, hold on one second. Um, and usually we'd like to start these events, which is really important, with our land acknowledgement. So I'll go ahead and start with that right now. We at UCR would like to respectfully acknowledge and recognize our responsibility to the original caretakers of this land, water, and air, the Cahuilla, the Tongva, the Luiseño, the Serrano peoples, and all their ancestors and descendants, past, present, and future. Today, this is the meeting place and home to many Indigenous peoples from all over the world, including UCR faculty, students, and staff, and we are grateful to have this opportunity to live and work on these homelands. So I'm Denise Martinez. I am the Associate Dean of DEI here in the School of Medicine, and it is an absolute pleasure to be here today. We are delving into a crucial topic, which is the intersection of health and social justice. And with Dr. Sims' lecture, The Social Determinants of Cardiovascular Inequities, we celebrate today Black History Month, as it's essential that we continue to recognize the profound impact of historical and current systemic injustices in health outcomes. We acknowledge that health equity lies at the heart of the mission of our institution, and that these discussions are extremely important to our commitment for advancing health equity. We are fortunate to have a national leader in Dr. Sims to talk in this space, and we are excited to have and hear more about his very, very important work. So I'm going to share his bio. It is a nice, very extensive bio, so I hope I do it justice. So Dr. Sims is a full professor of social medicine, population, and public health in the School of Medicine at the University of California, Riverside School of Medicine. He is a graduate faculty director of the MPH program in SMPPH, which we are so excited about. He is also co-director of the U54 NIH Health Disparities Research Center at the UCR School of Medicine. He was recently professor of medicine in the Department of Medicine at the University of Mississippi Medical Center and chief science officer at the NIH-funded Jackson Heart Study. He is also the interim director and principal investigator of the Jackson Heart Study. As a social epidemiologist, his research focuses on understanding cardiovascular disease disparities, with a specific interest in examining the extent in which racism, stress, residential segregation, and psychological factors influence CVD disparities, cardiovascular disease disparities. He has been the PI of NIH-funded related social determinants of health and resilience of CVD among African American adults. Dr. Sims has published over 240 papers in scientific peer-reviewed journals and has given over 235 professional presentations at scientific conferences, symposia, and grand rounds. He is the immediate past chair and Social Determinants Committee of the American Heart Association's Council on Epidemiology and Prevention and the Council on Quality of Care and Outcomes Research. He sits on the advisory board for the NIH National Minority Health and Health Disparities Institute. He is also a member of the NIH Clinical Data Science Institutional Review Board and a member of the Observational Study Monitoring the National Heart, Lung, and Blood Institute American Lung Association Lung Health Cohort Study. He is a fellow of the American Heart Association, and he was recently elected a member of the National Academy of Medicine, which is just stellar. So please welcome Dr. Sims.
All right, thank you for that introduction. Can everybody hear me okay? I will use, turn the pack on? Yeah. All right, I think we're good. Can you hear me now? Thank you. So thank you for that introduction. I'd like to thank Dr. Martinez in our office for inviting me to speak to you today for such an occasion. And I'll try to follow up the introduction with a with a commiserate presentation. So thank you for that. I'll talk to you today about social determinants of cardiovascular inequities. And let's see, we get here. Let's see. Oh, down. Okay. So what inspired my research? Why have I chose this area of research? Well, I grew up in Compton, California, youngest of 7 children, lived in lower to middle class neighborhoods. So I've always lived in areas where I saw that socioeconomic conditions impacted health outcomes, right? And what put that over the edge was reading The Philadelphia Negro by W.B. Du Bois, which is a seminal piece on not only just sociology, urban studies, epidemiology, just a number of factors were hit on in that seminal work. So after reading that book, I really became inspired to look at the connection between social determinants and health outcomes in underserved communities. And principally, he was looking at more or less infectious diseases at the turn of the last century and numerous social determinants. So it's a very, very copious study. And I also learned how to study my community through mentors that I had in undergraduate and graduate school. So I like to recognize those persons who really served as a nice springboard into the work that I've done over the last 25 to 30 years. Okay, so let's delve into the overview of the presentation. So essentially, I'll talk about some concepts as far as what are health disparities, health inequities, health inequalities, and then we'll talk about the need for studying social determinants of health, as well as how they impact cardiovascular disease using the Jackson Heart Study, which is what I've used over the last several years. And we'll talk about findings in 4 domains of social determinants of health. And then we'll delve into research and policy transformation and why they are needed to achieve health equity. And we'll have a conclusion by then. So this shouldn't take that long. To begin, health disparities or health inequalities. Health disparities do not refer to all differences in health, as some people use it in the wrong manner. But health disparities or inequalities, a health disparity is a difference in which disadvantaged social groups systematically experience worse health or greater health risks than more advantaged social groups, okay? And so a health disparity is a difference in which disadvantaged groups such as poor, racial ethnic minorities, women, other groups who have persistently experienced social disadvantage or discrimination systematically experience worse health or greater health risks than advantaged social groups. And social advantage refers to one's relative position in a social hierarchy as it relates to wealth, prestige, power, and the like, okay? And health disparities or inequalities include differences between the most advantaged group in a given category, that is the wealthiest, the most powerful racial and ethnic group, and all others. And so it's not just differences between the best and the worst groups, right? You know, that dichotomy. So really, I think it's necessary to qualify some of these terms so we can understand how to engage the research to come up with the answers and solve the problems that we want to solve. Okay, so pursuing health equity means pursuing the elimination of disparities and inequalities. So you can use disparities and inequalities interchangeably, right? So health equity, what does it mean? Well, it means that everyone has a fair shot at living the healthiest life possible. That's basically what health equity means. And achieving health equity requires valuing all individuals and populations equally, recognizing and rectifying historical injustices and providing resources according to need. So, and according to Paula Braveman, seminal piece in 2017, attaining health equity requires addressing obstacles to health such as poverty, discrimination, and their consequences, including powerlessness and lack of access to good jobs with fair pay, quality education and housing, safe environments, and quality health care, okay? And so achieving health equity requires valuing all individuals and populations equally, recognizing and rectifying historical injustice, and providing resources according to need. Just to emphasize that point, which is important to bring up. So let's talk a little bit about social determinants of health versus social determinants of equity. Okay, so while social determinants of health are the conditions in which people are born, grow, live, and age, the social determinants of equity are the systems of power, okay? The systems of power. So if social determinants of health are the context in which individual behaviors arise and convey risk, the social determinants of equity determine the range of contexts available and who is found in which context, if that makes sense. So the social determinants of equity govern the distribution of resources and populations through decision-making structures, policies, practices, norms, mores, values, and too often operate really as social determinants of inequity. So that's even another term that can be born out of this type of work. By differentially distributing resources and populations. Okay, and these include examples that we know of, that you know of, include examples like racism, sexism, heterosexism, ableism, ageism, capitalism, all the isms. Okay. So this slide highlights what was mentioned in the previous slide, right? And this is the World Health Organization's Social Determinants of Health framework. I always like to present the framework that I'm working from because it helps people to see, and it really helps. It helps your location in the discussion and in the dialogue of a particular topic. So I think this is important to take a moment to look at. So as we know, the social determinants of health are the conditions in which people are born, grow, live, work, play, all those good things, age. And these circumstances shape, or these factors shape life downstream, right? They're shaped by the distribution of money, power, as we said, resources at a global, national, as well as local levels. And the figure specifically displays the impact that socioeconomic and political structures, things like governance, policy, and how they impact socioeconomic position, right? Like one's education, one's income, one's occupation, which impact downstream material resources. This is so high, let me see. Material resources such as one's material environment, food availability, living and working conditions, and then it impacts other factors which are proximate in the pathway to health inequity or equity. Things like behaviors, biological factors, psychosocial factors, and how that intersects with the health system, and then has a direct as well as an indirect impact for health and well-being. And so a lot of my research had focused on the portion of the figure that looks at socioeconomic position on, and I'm starting to look at some of the upstream factors. I've been able to work on certain policy papers with publishing data with the American Heart Association on what we call scientific statements. And so that's been fueling a lot of the questions that I want to start now proposing in some of the research that I actually look at, okay? Here we go, okay. All right, so CVD mortality is a major disparity that's often measured between racial and ethnic groups. It locates where people are. You know, it tells a story of inequity, access, a number of things, where you potentially would live, and a lot of other social determinants. So this figure shows the age-adjusted total CVD mortality rates by race and ethnicity between 2008 and 2018. Okay, and again, we see that CVD mortality has declined for each group over time as there's a monotonic decrease over time, which is what you would expect from 2008 to 2018. However, in 2018, we see that Black adults are 32% more likely to die from cardiovascular disease than are other ethnic and racial groups. So the groups are on the x-axis and the y looks at the rate per 100,000 adults for mortality. And this map displays what I like to call the conflation or the intersection between social determinants of health and cardiovascular disease risk factors, okay? And it's very eye-opening. This is furnished by CDC. So we see that the top maps show the geographic distribution of cardiovascular disease risk factors, right? We see obesity, diabetes, heart disease, cancer. And the bottom map shows the geographic distribution of sample or selected social determinants of health, right? Education, employment, poverty, and the Black population. And so we see that areas with high poverty are also areas where there's higher rates of heart disease, right? Areas where there's mostly less educated persons and there's high unemployment, high poverty, also are areas where there's a high concentration of African Americans. And that's usually in the south and eastern portion of the United States, okay? And areas with low poverty have lower rates of heart disease, okay? And those are areas where African Americans are more likely to live in these non-poverty areas where they also have lower rates of CVD. CVDs like hypertension, also obesity, dyslipidemia, inflammation. I mean, the list goes on. So what's the point here? I think you can see the point. There's a need to understand the multiplicity of socioeconomic and psychosocial factors that impact cardiovascular disease disparities. And this is what I've been working on for the last 25 to 30 years. Man, time goes by. And examining these questions and trying to provide certain answers, understanding, filling the gaps in the scientific literature in order to start, really trying to do something about it to help mitigate these factors. So this is an important slide because it gives a good pictorial of what we call the embodiment of social determinants of health and how they relate to what we call a biology of adversity, okay? So we see that there are different layers here. You have social determinants, chronic psychosocial and environmental stressors, inflammation, and then the development and progression of heart disease. Okay, so there are connections between social determinants of health and biological pathways, which leads to inflammation, which are the first two levels. And then we know that social determinants are sources of stress that people face, and they impact people's lives. What do they result in? They result in things like exposures to certain things like neighborhood violence, low socioeconomic status, food insecurity. I mean, the list goes on and on. Limited health care, unsafe and insecure housing, social isolation, discrimination, and a number of things. And so following that, we have a biologic adversity that promotes pathways to chronic inflammation, which is a major risk factor for heart disease, right? And ultimately result in risk factors for cardiovascular disease, what they call MACEs, or major adverse cardiac events. And so, for example, we see the SAM axis and the HPA axis are activated by stress and regulate the production of catecholamines, then impact downstream risk factors for coronary heart disease. So that adverse pathway is very important. It's how that inequities or inequalities get beneath the skin, okay? So let's talk a little bit about some of the work that I've done over the last few years. I've looked at the Jackson Heart Study, where I was a chief science officer and an investigator. And so the Jackson Heart Study is a study of cardiovascular disease among African-American men and women in the Jackson, Mississippi metropolitan area. And it's a collaborative effort among these four institutions: the University of Mississippi Medical Center, which is where the coordinating center was located, and the field center, where we collected the data for the participants, from the participants. And we also we're in partnership with Jackson State University, which has one of the undergraduate training centers, and as well as graduate training centers. Tougaloo College it's an HBCU, and they have one of the centers for undergraduate training, as well as the Mississippi State Department of Health, which is mainly our mechanism for involving the community, doing CBPR research, pilot granting to people doing research in the community, partnering, having the community really drive, being a major driver of that piece. So the primary goals of the Jackson Heart Study was to broaden research of cardiovascular disease risk factors among African-American adults, increase access and participation of African-Americans and other minority scientists in the biomedical research and professions, and implement outreach activities to increase awareness and promote healthy lifestyles in the community. It was a funded, well, it is a funded contract from the National Heart, Lung, and Blood Institute, as well as the National Institute of Minority Health and Health Disparities. It's been funded since 2000 to the present, okay? And it's currently in the field for its fourth exam, okay? It's a single site study. We enrolled about 5,306 adults in the Jackson metro area at baseline, which was between 2000 and 2004. And clinic visits occurred from 2000 to 2013. And the current exam is in the field. It ends in 2025. So we're collecting numerous new sorts of data points like brain MRI. We're doing a lot of aging related work, cardiovascular, echo measures, CT scans of the chest. Oh, no, that was me. And the like. So there are a lot of new, and we're also looking at more positive psychosocial factors, which may be protective of heart disease, right? As well as promote healthy aging. So we're getting more into that realm. Okay, and we also have annual follow-up interviews and cohort surveillance of the cohort is ongoing, where we surveil for hospitalizations for a number of things: heart failure, heart disease, or heart attacks, et cetera. Okay, so that goes into adjudicating some of our events for heart disease. So it makes it a very refined measure. Okay, and the sample was drawn from what we call the ERIC study, which is a 5-site study. It stands for atherosclerosis in communities, atherosclerosis risk in community study. And one of the sites was Jackson. And so NHLBI, the powers that be, said, well, we have some interesting findings going on in Jackson with the ERIC study. Why don't we focus on Jackson? And so that's how the Jackson Heart Study was born. There's also a random component, voluntary component, and a family component, which holds a lot of our genetic studies. We do some methylation type studies, GWAS studies, TWAS, another EWAS study. So there's a lot of geneticists around the world are partnering with us to what I used to say, because they're very just what's the word, energetic, and it's just fun working with some of my genetic colleagues. But anyway, we do a lot of linkage analysis and a lot of replication studies with these findings and other studies. Okay, and that's just this Tri-County areas in the South Central region and the state of Mississippi. And these are some of the components of the clinic exam. We collect data on demographic information, health history, medication use data, behaviors such as nutrition, physical activity, smoking, anthropometric measures, blood pressure. We also have an ambulatory blood pressure monitoring study, which measures blood pressure on a 24-hour basis. So that's been more robust of a measure than just in-office blood pressure where you average it between, 2 and 3 measures. So that's very, very robust. And we found that, well, I think I'm getting ahead of myself, but that's related to incident CVD among African Americans. That was the first time it was found in any study of a large sample size was in this study. Okay. And we also collect data on other laboratory analytes like creatinine, glucose, insulin, leptin. We do a lipid profile, plasma renin activity, aldosterone. So there's a number of measures. If you're interested in using these data to publish, please let me know. I have a capstone student who's working on a paper right now, and he's near publishing the data. He's almost done with the manuscript. He's my student. He's pre-med here, and it's been a real pleasure working with him. He's learned how to run his analysis with Stata, comb through the literature. So he's worked very hard on it. He's a senior right now, so I'd like to recognize him. Let me see. So some of the major findings from our study include the American College of Cardiology and the American Heart Association, as well as the Framingham Heart Study. CVD risk prediction works well in our sample. So it's a risk prediction tool that predicts your risk for heart disease, and it works well among African Americans. I know it's been tested right now in Latino populations, in the Hispanic SOL study, which has a site, I believe, in San Diego. We also found findings like there's high prevalence and low awareness of chronic kidney disease in our sample. More steps per day are associated with lower risk of metabolic syndrome. And again, as what I mentioned earlier, that mass hypertension is associated with the risk for CVD. So that was one of the groundbreaking studies that came from the Jackson Heart Study. So these are some of the data points that I use in examining the social determinants of cardiovascular disparities and inequities. So, these are some of the domains of them. There's a discrimination domain where we measure the extent to which you experience discrimination on a day-to-day level, the extent to which you experience it over your lifetime, and these are survey-based. Residential segregation, where you live in relation to not only people of different classes than you are, but people of different racial and ethnic groups as well. There's also socioeconomic status or socioeconomic position, where we look at individual and family income, education, childhood SES. So we're able to do more life course-based studies, which is very, very important. When you talk about the etiology of heart disease, which is rarely looked at, some of our contextual neighborhood measures include social cohesion disorder, violence in your neighborhood, social destinations, walkability, exposure to parks, things like that. So we look at the built environment as well. And some of the psychosocial risk variables include depressive symptomatology, measured by the CESD score, global stress, weekly stress, anger, hostility. So we measure a number of things. And then lately I've published work in the positive psychosocial realm, looking at optimism, how it's protective of CVD. And that's getting into a lot of, mechanisms, how that may happen from a behavioral standpoint, biological standpoint, network analysis, religiosity, et cetera. And so I'm also starting to consider collecting these data points here in the Inland Empire from a multi-ethnic standpoint, and looking at forming what would be a cohort study in the social determinants of cardiovascular health here in the Inland Empire. So stay tuned for that. So let's talk about the 4 domains of social determinants of health that I'll present to you very briefly in the domain of discrimination, social factors, psychosocial risk factors, and positive psychosocial well-being and resources. So the discrimination findings. So we know that there are hypertension disparities by racial and ethnic groups. Little research has examined the extent to which discrimination impacts hypertension risk. It has examined a lot of hypertension prevalence at one cross-sectional point in time, but never really got into sort of the longitudinal aspects of it from a prospective cohort design. So what we did is examine associations of everyday and lifetime discrimination. And everyday is the extent to which you perceive unfair treatment on an everyday basis, okay? And you can attribute that to a number of factors like Is it attributed to one's race, one's gender, one's weight? So we can get into weight discrimination, one's age, and we're adding another one, socioeconomic status. So, but we don't have that yet. So I won't, we talked about how everyday and lifetime are essentially associated with new cases of hypertension over time, and we use a Cox proportional hazards regression to estimate associations of this effect, and found that high versus low lifetime discrimination was associated with incident hypertension after full adjustment. So we have very robust findings. This is one of the first studies that showed it from a longitudinal standpoint. And I thought there were a lot of studies out there that had done this. So they kind of made they made a big deal out of it. I was like, oh, okay. I mean, it's important, but it's like, didn't you guys already know this? I think they knew, but nobody's really looked at it systematically. So, and what's interesting is that associations were present in women, but not men. And a lot of our findings have shown up more significant for women than men. And that, that tells you that something's going on from a mechanistic standpoint. Also, what psychosocial resources are available that might mitigate those effects across men and women. They may vary differently, right? So we're starting to get into, trying to explain some of those differences, which are very, very, very interesting to me. What this shows is just a sample of the other work that we've done in the realm of discrimination. So, we found that discrimination is positively associated with increased hypertension prevalence, subclinical disease like left ventricular hypertrophy, CIMT, and peripheral vascular disease. We found that it's been associated with health behaviors like sleep and smoking. The more higher levels of discrimination you perceive, the fewer hours of sleep you actually get. Okay, I'm sure I know we can identify with that. With stress being associated with those fewer hours. So this is just a realm of stress. And one study showed that everyday and lifetime discrimination were associated with reduced trust and satisfaction with one's healthcare provider after full adjustment. So very interesting work that we've done. And overall, we've shown that multiple domains of discrimination are important for considering cardiovascular disease risk factors in this type of work. The next studies that we've done relate to socioeconomic position and cardiovascular disease. And this is one example of a study that's in preparation. And so you see that, so here what we did is we examined the association of residential segregation and incident CVD as defined by coronary heart disease, stroke, and heart failure, okay? And I think that was, let me see, was that HFpEF or HFrEF? I think it was reduced ejection fraction heart failure. And so the method we use is that CVD events, we've since updated this, it says through 2011. I think that goes through 2018 now. We use the G-star statistic to measure residential segregation, which measures the extent to which you're exposed to people of your own race in your own census tract. That's the unit of analysis for the neighborhood. The extent to which you're exposed to those persons as well as people within your race and outside of your race, outside of your census tract, within the metropolitan area. So it's a very sensitive and refined measure of residential segregation. And we use Cox proportional hazard to calculate the hazard ratios. And so what we found is that a standard deviation unit increase in residential segregation is associated with a 12% increased hazard of CVD risk, only model 1. As you see in the first row, it attenuates over model adjustment. And the most robustly associated factor with residential segregation was incident stroke, right? So we see that even in fully adjusted models, there was a 15% increased risk of stroke after full adjustment. And there were no associations for CHD, which is usually used as more of a blanket term that includes other CVDs. So that should be published probably sometime. I have to get on the lead author about that. So anyway, yeah, I'm the senior on this one. So yeah. Other papers we've looked at in this realm of socioeconomic status and CVD include findings that we found that hypertension and diabetes, for example, are patterned by socioeconomic status. That is, The higher your socioeconomic status, the lower your prevalence of hypertension and diabetes, chronic kidney disease, and things like that, which you would imagine. But this was one of the first studies where it was done in a large Black population that had these data points, which I thought it was done before, but when we comb the literature, yeah, nobody's really doing that, really. So here you go. For example, one of the studies, we found that participants with high levels of education income had lower prevalence of, we looked at, I believe it was incident CKD. So this work has shown that SES is one of the major protective risk factors for CVD because it had that protective effect, or it's like a gradient, an inverse gradient. Okay. And quickly on the psychosocial risk factor findings. This slide shows a sample of our work that has been done in this realm. And what we mean by psychosocial risk factors, we're talking about things like stress, affect measures, negative affect measures, depressive symptomatology, anger, hostility, and things like that. So we found things like psychosocial factors, anger, stress, depression, hostility are associated with increased blood pressure progression, reduced hours of sleep, increased smoking, and risk of stroke, things of that nature. So there are associations among this population. And then in the realm of positive psychosocial findings, this slide shows well, we've been, I guess, pretty productive in this realm as well. So we looked at things like optimism, right? We're going to look at life satisfaction moving forward, and things like other resilience, what they call resilience markers. I really don't like that term because it's not really measured. It's measuring other independent domains apart from resilience. It can make you resilient, but it's not necessarily a resilient marker because there are instruments that actually measure those domains. So we looked at things like social networks, social support. Having more social networks was associated with a lower prevalence of type 2 diabetes. And we're looking at, my student right now is measuring whether or not that's associated with prospective changes of, prospective changes of diabetes, changes in blood plasma glucose levels, as well as new cases of diabetes. But that hasn't been done. So that's what we're going to include in my capstone students project. And we've also found that higher optimism was associated with lower odds of CKD and renal kidney function decline, and just a number of measures. So this work has shown that positive psychosocial resources are protective of risk factors for heart disease, and may be important points for considering targeted ways to prevent these factors in interventions and programs and things of that nature. So that's what this is moving us closer to, all right? So in summary, we found that there are multiple dimensions, multiple domains of socioeconomic or social determinants of health, which are critical risk factors in measuring and looking at cardiovascular disease inequalities, right? And we found that psychosocial factors and discrimination in particular are associated with CVD risk factors. So the novelty in this realm is that there are multiple domains of discrimination, which is rarely done or found or seen in studies. And there are multiple domains of psychosocial factors. So some of the knowledge gaps that we need to really hone in more to really unpack this is looking at time varying analysis. How do changes of these factors impact new cases downstream? And then also we found that CVD risk factors are patterned by SES. You know, they provide a buffer or a protective factor for one getting CVD or reporting prevalent diabetes, hypertension, or what have you. So the novelty in this area is that we've been able to look at area level measures of socioeconomic status, things like residential segregation, where you live, which are indicators of inequities, right? Indicators of the high level things that are still going on. Residential segregation. I mean, these things that we're still talking about after, 20, 30 years of the Fair Housing Act, things like that. And what does that mean? So we're sort of going against that, what it was meant to do, and things are still going on, and people's health and lives are being impacted by those factors. Some of the knowledge gaps in this area include there needs to be more life life course studies, as well as studies of wealth, because wealth is a true indicator of inequality. Income is not that good of a measure because that's more evenly distributed in the population, right? And wealth is not as evenly distributed. I mean, think about the own wealth that you have, or people that you know. So that's really, I think, something that really needs to be studied, as we're starting to find that those factors do predict heart disease very robustly. And number four, positive psychosocial resources are protective of cardiovascular risk factors and predicts cardiovascular health very well. I didn't talk about that, but that's some of you have seen my other presentations, so you probably can, mention that as well. But when we talk about cardiovascular health, we're talking about American Heart Association's what they call Life's Essential 8 metrics. These are factors that are factors that could prevent you from having downstream things like myocardial infarction, stroke, cerebral vascular diseases, et cetera. And they're just measures on an optimal scale. Well, like optimal tobacco use means that you don't smoke, okay? So that's one metric for, Life's Essential 8. There are 8 of them. There's optimal sleep. That means you're getting enough sleep. I think it's under 7 hours or something like that. There are optimal measures in glucose, BMI, so that means you have normal weight, right? And other factors. But that's, so a lot of my research has gotten really away from the risk side toward the predictive side of, a healthy profile. Because we want to be able to tell people, our participants and people in the community, what it means. What do you need to start doing? How does this go from, scientific publication to people's lives and changing people's lives? So that's what I think I really like that about the Life Simples. It used to be Life Simple 7, but now it's Life's Essential 8. And then understanding positive well-being and cardiovascular risk reduction points in the direction of targeted intervention and preventions that move us toward cardiovascular equity. We can change proximate areas along the pathway, things like behaviors, the cascade that goes from behaviors to inflammation, to risk factors, to endpoint states of disease, to address and mitigate and reduce and eliminate health disparities, to achieve health inequity. And I'll review two policy papers that we've started to get into that takes us from research. So we must also examine the historical context of structural discrimination and the state of current policies that have perpetuated society inequities, as well as the role of institutions play in making change. So institutions have a responsibility to make changes, okay? And as a recent past chair of the American Heart Association Social Determinants Committee, I served as a co-author on this paper on the policy. It was a policy-related position paper where there's a call to action. And, the major thing is that the structural drivers of health inequities. This is the fastest that I've published a paper within a month. I think the president of AHA asked us, or kind of, I guess, deputized us to write the paper. And we put it out in about 3 to 4 weeks. And so the background of it was, talks about previous statements have not really examined structural racism. And, with the proliferation of police inequalities, juvenile justice reform, the George Floyd case, the COVID, these things sort of really creating this powder keg for things to just explode, happen, stay the same, and not change, and only get worse. Worse in people's lives, their health, etc. So the objective was to review the historical context, current context, and potential solutions to address structural racism in the U.S. And so some of the major findings is that we looked at the historical context of structural discrimination. We looked at all groups. So it's a very packed paper. And looked at how that there were origins of institutional inequities among underserved minority groups. And so future policies must be implemented at the individual, community, and population levels to achieve health equity, which was the major point. And it also talked about the responsibility that the American Heart Association has to make changes, to partner with folk in making these changes. And this was a latest paper. This is, I think, my last slide. The latest paper that looked at addressing structural racism through public policy, how we must use policy levers to make the change and things. And I listed a few. I think we listed maybe about 20 in the paper. So the issue is access to quality care. The policy solution is affordability and care for all. What are some of the specific changes that need to be made? Advanced Medicaid expansion, mitigate proliferation of substandard health insurance products, et cetera. So these are some of the studies that we're starting to get into now, which then will follow certain research aspects of making these changes. One domain at a time. You can't solve the whole world in one paper or one study. I'm sure some of you realize that. And so other policies to address structural discrimination included healthy food access, nutrition security, environmental health, and a number of other factors. Okay. So in conclusion, structural racism is embedded in multiple structures and shapes the lives of people in the U.S. And it shapes the aspects of social determinants of health as well as social determinants of equity. And there are multiple ways to obtain health equity. In research, knowledge is gained. Interventions, lives are changed. Community-based programs, communities are transformed. In government programs, specific areas are changed, be they housing, food security, income, education. So leveraging and changing upstream policies at the structural level must occur, right? And so I leave you with this quote by W.B. Du Bois from the Philadelphia Negro. Broadly speaking, the Negroes as a class dwell in the most unhealthful parts of the city and in the worst houses. The part of the population having a large degree of poverty and social degradation is usually found in the worst portions of our great cities. And I would like to say that that has not changed. I think that still occurs, maybe on a different scale. It speaks to the topic that I've talked to you about today. And perhaps when parity is reached, then proper clinical and public health prevention and interventions can be developed to address and eventually eliminate health disparities by race, ethnicity, and other factors and achieve health equity. So with that, I'm done, and I thank you. And so I'll take questions.
Thank you. Thank you so much. That was really excellent. Really, really appreciate. So now we have time for a few questions. It looks like we do have a question. Want to start first online?
Yeah, we have two questions from online, both from Dr. Osei. Would you say social determinants of equity could also be called political determinants of health?
Wow, that's a really good question. Political determinants of, say that again?
Would you say that social determinants of equity could also be called political determinants of health?
Yeah, I mean, I think that's a component of it. Because when you're talking about equity, you're talking about those factors that are determined politically at those levels. And they could very well determine whether there's parity or not, or equity or not. So I think, yeah, I think that very well could be a component of it. Thank you very much, Dr.
If that
Osei.
term is not coined, I think Dr. Osei should coin that term.
Oh yeah, and I love it. And we can't use it. It can't be so use it perniciously, because when we use the term political, sometimes we say it's just political, you know, and that usually get a negative kind of context. So it has to be contextualized and sort of qualify what we mean by that. Right, right.
And her follow-up is, can you comment on the effect of these chronic illnesses in caregivers on the risk of psychosocial dysfunction in their children?
Wow. I just got on the phone. I had a meeting yesterday with somebody about this very question, about the extent to which chronic caregiver stress contributes toward heart disease. And so it is a finding. We know that from the literature, but from I think she means maybe from a family component, how it may impact one's children. That certainly is also a finding in the literature. It does have effects on one's health, stress levels. I raised three kids, so it wasn't easy at times. It's stressful, you know. So even in the best of times, those stressors can impact you, because some of the caregiver stress literature, they talk about the ability of adults to care or not care for themselves, as well as children under a certain age. It varies in a lot of research. Some say below 5, some say until they get 18. Mine still are calling, and they're all in their 20s, and one is in, anyway. So that's another issue. But anyway.
Are there any questions? Yes.
Mhm.
Okay, thank you. So thank you for your talk.
Mhm.
I really was struck by the findings around gender. And so you mentioned that this seems to be a common pattern
Mhm.
that African American Black women tend to be at higher or demonstrate higher risk for
Mhm.
cardiovascular disease.
Mhm.
And so it says to me something about power relations across multiple different spheres: employment,
Right.
economics, personal relationships, family relationships. I'm just wondering if you can comment on that, particularly when we think about, so what can we do? And I know you
Mhm.
also mentioned your work is moving towards structural level intervention. And so if there's any ideas that you could share with us about how we might think to move forward more structural level interventions as ways to uh, reduce the risk for women in particular with
Mhm.
minoritized identities.
Yeah, those are very good points. We're still wrapping our heads around the gender differences in our findings. It is certainly a factor. The first thing I think about when I see the results coming out, looking at the results is residual confounding. Oh, okay. What aren't we measuring? That's the first thing I think about. What are we not measuring? And you could be measuring various factors, but are you measuring them accurately? Because one size doesn't fit all. And some people try to do that with various measures. So not only what are we measuring, but what are we not measuring, but what we are measuring, how does it need to improve? To get things like the dynamics of family inequities or power relations at work. Are we looking at financial strain? Are we looking at authority? Are we looking at satisfaction? Those things matter. Those things matter. And I think I think it just takes sort of, I don't know, scaling a lot of that to where you look at it cumulatively and try to disaggregate some of the independent factors that may have impacts on their health. Things like the psychosocial, things like the income, the life course. And so in a lot of this research, it's mentioned that there's a triple jeopardy, particularly for African-American women, and even just minoritized women. I can think about, the case similar probably for Latino women's, for tribal community, indigenous populations. And so I think more needs to be done in that angle. Also measurement, the way in which we measure them and what aren't we measuring is really important. As far as your second point, we're starting to think about, lately they've been asking me to write about it more from the structural standpoint. They say, well, you've done all this research, so what do you think from a policy standpoint? Just taking a survey of the policies that are written and how changes in those policies might impact or change health inequities or achieve health equity. And so I've been invited on these papers, but they make me think. Okay, so how do you research this? How do you do it? Well, I think we just had a conversation with Dr. Wolfson and looking at certain policies from an aggregate standpoint and looking at pre and post changes in people's lives, behaviors, and how that impacts their downstream chronic diseases, things like diabetes, things like inflammation, things like that. So I think thinking about them from that standpoint at this juncture for me, I think that would be the start that I would sort of give that type of research from an intervention and a macro level type of perspective or approach to it.
I think we have time for one more question.
Can I ask? I was going to ask the same question that Dan asked, but that's all right. Thank you, Dr. Sims, for the excellent work and the talk. One of the first slides that you showed had African Americans with very high incidence of cardiovascular disease, and Hispanics seem to be at the other end. And at least in a lot of areas, they are under the same social determinants. I'm not I'm a biologist, so I don't even know how to use the terms properly. Why?
Very, very good question. Well, there's several reasons. I don't have all the reasons, but I can tell you what I do know on that subject. I think that number one, it's usually an aggregate measure. So it's putting all Latino, Hispanic populations in one category. That's going to have an impact on the prevalence. And also, too, is that it's usually, again, a residual confounding. They're usually excluding certain subpopulations and including measures of refinement, measuring heart disease in those subpopulations. So you have low numbers. Also, another factor that researchers in this space have really talked about as far as explaining what they call a Hispanic paradox. I think some of you may know about that. And so they're saying that, okay, you've been in this country, particularly those who are foreign born or even native born, but you've been in this country and you're exposed to the same risk factors as other minority groups, yet you're coming out looking different on certain chronic kidney disease or chronic diseases factors and things like that. What's going on with that? Is it that your environment is shielding you, helping to reduce the impact of stressors, of discrimination, of, what factor is protecting you? Is it family? Is it networks? So I think some of that is also at play in looking at those numbers. Okay.
So thank you so much. We really appreciate it.
Thanks.
It's about 1 o'clock. So thank you so much for your time.
All right.
And I'm excited to hear that maybe we can continue some of this work in the Inland Empire, which is also so exciting and potentially really important. So thank you so much. And thank you all for coming today.
All right. Thanks.